So we were talking about how the physical therapist and a physician, anything that's used to achieve proper body alignment or balance or protective devices are not considered mechanical restraints. Anything that's going to address a person's medical condition. Physical restraint means a department-approved physical intervention used to restrict an individual's movement, to protect the individual or to prevent self-injury or injury to another person. And then finally, chemical restraint, which could certainly be a PRN, means it's a psych medication that's administered on an emergency basis to an individual who's in danger of harming themselves or another person, and when all other interventions have failed. And medications that are used for pre-sedate for a medical or dental procedure are not considered chemical restraints. We do get that question pretty often. Okay, we can move on. Great. So in PR 004, there's restraints specifics that are found in Section D, which is entitled Implementation. So the PRC guiding principles, B is the PRC presentation, addresses the PRC presentation for the initial use or modification of floor control, and a prone or face down restraint, which is strictly prohibited. I'm sure everybody knows that. Number 2 is PRC membership and charge. Section C is the regional PRC reviews, regional PRC reviews and makes recommendations, and then approves the use of, in Section 3, any behavior plan that contains the use of aversive procedures. That includes new behavior strategies or changes to previously approved BSPs if they include an aversive procedure. And number 5, at the request of the individual's planning and support team, when there's either been 1, emergency restraints that have been used more than 3 times within the 30-day period, or 2, there's a pattern of emergency restraint, as in once a month for 3 months or some other similar pattern. And we really wanted to stress here that 3 times is considered a minimum for when you may want to, think about making an emergency restraint into a planned restraint. And we can certainly talk more about that after, if that's what people wish. Okay, thanks. I think everybody's probably familiar with this. This is the request for program review committee for a date to review behavior modifying medication or restraint or aversive procedure. So this would be filled out if you're going to be adding a restraint of any kind to to a person's behavior program. Obviously, changing medications and aversive procedure, all right there in the middle section of that that form, you'll see that. So as soon as you know that that's going to be something that'll be part of somebody's program, please fill it out, send it in, and we will get you a date as soon as possible. Great. So some considerations when adding restraint to a behavior support program. This is kind of a longish section, so please bear with me. But we think that this is probably important to think about. You want to review any other intervention and measure that you've tried before adding a restraint to the BSP. It's helpful to fully explain the success or failure of less aversive measures to help staff, other clinicians, and PRC members, even licensing, understand what led the team to the decision to use restraint. So monthly risk reviews, sometimes teams do those just to kind of look over the 255s, what's been happening, is there a pattern, etc. There are some review factors that could certainly contraindicate the use of restraint. So history of trauma and abuse from either family, staff, law enforcement, medical professionals, if the person's been in an institution, and certainly any past responses to any type of restraint that you're aware of for the individual. There are also situational and environmental considerations that could increase the risk for restraint use. And these are not in any particular order, but prolonged agitation during a restraint, that can be an indicator of a trauma response, sensory integration or processing problems. It does become a significant risk and a concern as it increases the person's demand for oxygen. So physical struggle, anxiety, strong emotion, all of those are going to increase the body's demand for oxygen. Prolonged restraints, anything that's longer than 10 minutes, people tend to be at a higher risk, and because it indicates increased agitation. So pressure to a person's neck, chest, or abdomen, a hot or humid environment, which certainly makes it harder to breathe to begin with, prolonged restraint. So, oh, I'm sorry, that's a repeat. And if the person complains of pain during the restraint, that's another consideration. If you could change the slide. Thank you. So any change in coloration during restraint that indicates a circulation problem, that's a significant risk factor, and there should be immediate release. There's a note that indicators differ across complexions. So darker skinned individuals become more pale, lighter skinned individuals get more bluish or purple, and people of Asian descent tend to develop a more greenish tone. So that's important to know. Intoxication, alcohol or drug use during a restraint, that affects breathing and the brain's control of breathing, of course, making it less likely for the person to be able to reposition properly to allow them to breathe effectively. An active psychotic state, delirium, or extreme arousal like mania, any recent head injury or other significant injury, prolonged restraint that follows a physical struggle or violence that caused fatigue, and a person is small in stature, recent insulin injection. There's some medical considerations to keep in mind that can increase the risk for restraint use: cardiac or pulmonary conditions, asthma or emphysema, chest deformities, any kind of recent injuries like strains, sprains, or fractures, an enlarged heart, prescribed medications that may obstruct breathing or a cardiac rhythm or system, high blood pressure, obesity, seizures or seizure disorder, sickle cell anemia, and diabetes. And again, this is not by any means an exhaustive list, but those are some, kind of top medical considerations we want to look at if we're thinking about adding restraint. A common question that people have is when to release restraint. Best practice suggests that you agree to release the restraint after a specific number of minutes, ideally as few as possible. We mentioned previously in previous slides, less than 10, no more than 10 minutes, and then immediately give the person space. We're not recommending the use of until calm as a release method. The team really should be conducting a risk-benefit assessment and conclude, if it does conclude, that is the best approach, but always specifically defining calm for that individual. And that's, I just want to add to that, that's not necessarily always the absence of the behavior that maybe kind of snowballed into this restraint. It can also be, what do we want to see this person doing? How do we know that they're actually calm? Okay. Chemical restraint. Ideally, there should be a protocol for use. As with any restraint, it needs to be thoroughly justified through documentation by the team. The use of a PRN for any behavioral reasons, which we're of course defining as chemical restraint, requires the development of a detailed and well thought out protocol for use. So the protocol really needs to be developed with and approved by the prescribing psychiatrist, the person who's giving their recommendation for the medication to use. The team RN also has to review and approve the protocol. Any staff certified to pass the meds are trained in the use of the PRN per the written protocol. The protocol should contain details of the criteria for initiating PRN use, notifying the RN of when it's going to be used, the actual administration, the documentation of use, and of course, observations of the individual receiving the PRN, such as vitals. There may be other things we are observing as well. Any additional doses and PRN discontinuation. And with the team always looking forward to and planning for titration of the chemical restraint if possible. I also want to talk about in your behavior program, if restraint is going to be part of it, the hierarchy of restraint use. So it's important to outline that. We of course want to describe it from the least aversive to most aversive. So meaning the least aversive is used first, move to the next level with floor control, chemical restraint being the most aversive. or floor control and chemical restraint, I should say, being the most aversive. So an example would be maybe you start with an escort, maybe a lower figure 4, excuse me, a seated hold, cradle or basket hold, commonly referred to as, and then a floor control. So always provide guidance as to when to progress through the hierarchy. I've certainly seen programs where it's just kind of lists it, but there's no real guidance as to when we go from an escort to a lower figure 4, or when you're going to floor control. What's that? What triggers that? Providing criteria for when to discontinue the restraint. So again, it's not just observable behavior, it's observable behavior, but not just the absence of behavior. And when you're titrating restraint use, always, remove the most aversive first. And it's not necessary that everything needs to be continued all at once if there's more than one type of restraint that's being used. And that's it. Thank you. And thank you for listening to me yell at my husband.
Thank you, Dawn. So, as stated earlier, if you could hold questions till the end, we are going to go over all your questions that you had submitted ahead of time, and I'm sure this will elicit some questions as well. So the next topic, is incident reports. So we're going to talk about, the incident reports. So many eyes look at these. And so I just want to kind of pause and talk about the broader, mission of the department. So, we're here to work with individuals and their families to meet their goals and help them function, as valued members of their communities. So sometimes we can get very task oriented about, reports and what we have to do, but I just, it's always important to remember why we're here, what we're really doing, what the big picture is. So, as we ask for incident reports, let's remember, the purpose, the broader goal to support people and responsibly serve them. And the department asks for these reports to review from various angles and lenses. So, we're trying to give clarity here on the content, in spite of the fact that many of you don't fill these out at all, and maybe, don't see them until well after the fact. But, some of you are part of training on how to do so, and some of you might be part of completing them. So, if you can take this in and try your best to, take in what you can, and we'll try to improve as well. And the policy, just another caveat, the policy is in the process of being revised. So this is a snapshot in time of now of what it looks like. And we do acknowledge, some of the imperfections in our system and our policy, and the challenges of functioning within it. So, just keep that in mind as well. We're trying our best, and we know you are too, and we're all on the same team. So bear with us. All right, so the major 4 types of restraints, that are listed in incident reports are here. Just keep in mind that this policy specifically applies to DDS operated, funded, or licensed facilities and programs. It does not apply to individuals living in their own or their family's home. Okay, there's a separate policy for that. So as we talk about, incident reports, I'm going to go over the details as to what each of these 4 topic areas are. So an injury is defined as a physical trauma. It counts as an injury even if you don't know what caused it because you didn't see it happen. So minor injuries are not included on 255s. You can put them into a minor injuries log. And a minor injury means there was no treatment, or maybe just a minor first aid, like a Band-Aid on a scratch or something very, very small. Whereas moderate injuries require an assessment or treatment by a nurse or a doctor. It could be like a broken bone. And then a severe injury requires a hospital admission. So not just an ED eval. And, of course, these are also critical incidents. So naturally, deaths due to injury require 255 as a critical incident, as well as the completion of a death report. All right, so the next item is unusual incidents. So these are pretty all-encompassing. Anything that's dangerous, illegal, the police are called, a fire's been set, the emergency department has to assess, or there's a behavioral concern that wasn't already in the behavior support plan, but it's worrisome. A hospital admission that's not related to an injury. So the rule of thumb is if it worries you, it's probably going to fall into the unusual incident category. So fill out a 255 for that. And then, of course, we have medication errors. These would go into a 255M, but I won't go into the details of those because those are covered in med-surg classes. And then finally, our topic of the day, restraints. So incident reports are required for both emergency and PRC approved restraints. Okay. There was a lovely 2011 executive brief, which gave some helpful guidance around why the 255 was changed. And at that time, it was changed to remove mitts, helmets, specialized clothing, buckle guards, things like that. So now the data for that is collected separately, and it would be reported in your quarterly or biannual reports, as well as, bring it to HRC. The reason you would be reporting on that is to ensure the FAID plans are followed, for those restrictives. So you need to have a data-informed FAID plan. So be sure to be tracking the data related to those and reporting on that as a team. All right, so, as we go into the pieces of a 255 that are pertinent to restraints, I'm just going to highlight a few of the sections specifically around restraints. So here I've circled the top there, and notice it says final date out. So the reason that this says final date out is it's if you're planning to submit a log that it is attached to the 255 that has a number of restraints on it. Okay, so you can submit multiple PRC approved restraints on an attached restraint log, and we'll talk about caveats as to when and when not to do that. But the top of the restraint form would say the initial date, and then the final date out would be the last date that's represented on your attached log. All right, so this next section is, the types of restraints that were employed. These are, as you can see, this allows you to check up to 4 restraints that occurred in one given behavioral event. So be sure to include all restraints that were applied in the incident, okay? Keep in mind that this may otherwise be included on an adjoined log, so obviously you wouldn't try to include every restraint if you're attaching a log. That's going to be separate. And we'll talk about the definitions of each of those restraints shortly. And now we have the behavior section. So similarly, you can check up to 4 behaviors that occurred in one behavioral event, okay? And again, this would be on an adjoined log if you're attaching a log. Now, the status. This one trips us up sometimes. So keep in mind that the status will be either emergency or PRC, HRC approved. It's either one or the other. Now, if an injury is caused by the restraint, this also requires RN follow-up. This requires a separate, incident report. You can't do a log with if an injury is caused by the restraint, but be sure to check that off, yes or no. Monitoring, at least every 30 minutes, is done by someone not involved in the restraint, and this is required if the restraint lasts 30 minutes. Monitoring, you could do certainly more often than that, but that's a minimum requirement. And this might be involved if, you want to check on the person to make sure they're not in distress. And I mean, people administering the restraint should also be paying attention to these signs of distress, as Dr. Racinos went over a number of them. So are there signs of discoloration? If so, did you terminate the restraint? These are things you want to be monitoring. Was there labored breathing? If so, did you terminate the restraint? Were there complaints of pain during the restraint? If so, was the person released and repositioned if they're saying they're in pain? So remember that if it's a mechanical or a physical restraint that's employed for 50 minutes, the person needs at least 10 minutes every hour to get that part of their body exercised. So that's what that means, exercise at 10 minutes every hour. So like if mitts are on or something like that, obviously that wouldn't be on a restraint protocol, but if some of the other mechanical restraints are being utilized, you'd be sure to monitor that and make sure that they get a break every 10 minutes or 10 minutes every hour. All right, here's another one that tends to be challenging, this section here. The person applying is the staff restraining. And now remember to include additional staff if you need more than one person for the application of the restraint. Make sure all names are represented. The in charge is the lead staff on during the restraint. Sometimes this is missing from incident reports as well. The person removing is like for a mechanical restraint removal. Emergency restraint trauma check occurs within 24 hours, but it's done by, the RN or representative to ensure there were no injuries sustained, Often they're checking skin integrity, bruising, things like that. And some agencies have a body trauma check that they attach to the 255, which is really helpful to make sure everything is assessed adequately, and that person would sign off there saying they've done their trauma check post-restraint. Now, the bottom I didn't include, but the summaries and comments, or summary and comments section. So that we want more information always. You want to talk about the precursors, the events and the strategies that were used to try to calm the person prior to having to use a restraint. The level of supervision should be reflected clearly in the content of the summary. Sometimes when this is missing, it raises a red flag and makes you want to call AID for neglect, just to be sure, because if it's not clear, you wonder. And if additional staff are present to assist, sometimes they're ensuring the safety of other individuals, during the situation. Represent that as well in the report, because their role is important and it needs to be included in the summary. So it's clear, what happened, what was going on, what were the circumstances, what did we do? All right, so I'm sorry for this busy slide here, but I thought it was helpful in a way. So we talked a minute ago about the restraint log. And there's, attachment D, which you can find in the DDS manual online, that shows you what a restraint log looks like. Now, the restraint log can be attached if you're reporting on PRC approved planned restraints that occur regularly, and the team agrees that using a log is appropriate. So keep in mind that switching to a restraint log results in a delay in reporting. Okay, and it also results in less documentation because the summary section with all the details we were talking about is excluded if you use a log. Okay, now the team would assess this and say, is it worthwhile, or is the circumstance one that we wouldn't want to lose that vital information for this person? So if the team agrees that the restraint log is appropriate for this person, it's routine restraints that don't have a lot of other concerns around them, then the team will also agree upon a set time frame for the submissions, and it needs to be no less than once per month. It has to be submitted at least once a month, the log of the restraints used that month. Now, keep in mind that if an injury is caused by a restraint, the entire event must be included in a separate 255. So that 255 should represent both the restraint and the injury, as well as all the details and circumstances around the restraint and things that led up to it. The log should not be used to document the restraint if an injury is caused by it, just to be very clear. All right, and as I mentioned before, I have this little handy arrow pointing to the incident date and the final timeout. So that's the range covered if you're using a log. All right, and here is what the DDS log looks like. So that's an example from the DDS manual online. Note the information that's documented with each restraint. The last column does ask whether there was an injury caused by the restraint. So if there is, make sure there's a separate 255 that's completed to document both the injury and the restraint. We want to make sure that if in the case of an injury, all the surrounding events and circumstances and details are provided. So that's why we need a separate 255. And as you are well aware, reviewers are going to consider whether an AID call is warranted if an injury is caused by a restraint. So all the more reason to be sure we're proactively documenting as close as possible to the event. All right, so now we'll go into those details about each type of restraint that is on the 255. Dr. Racino's reviewed chemical restraint circumstances earlier. So just a brief reminder, these are, behavior modifying medications administered as needed after other interventions have failed. And we need to have a very detailed plan, and presedates are not included as chemical restraints. That's a different circumstance. Don't do 255s for PRNs or presedates, only for PRNs for, restraint purposes. All right, so an escort, and now defining an escort is important. And this is in policy as well, but it's physical redirection used when the individual is resisting. So remember that restraints involve restricting movement, so the individual can't pull away. So this will be a block, whereas gripping, holding on, limiting movement, using more than one hand is a restraint. So if there's no resistance, it would not be called an escort. Rather, it's more of like a guide along or a guide to help someone get from point A to point B. It's a restraint, an escort, if they're their movements restricted. Now the floor control, the supine face up floor control, now face down restraints are strictly prohibited for DDS funded individuals. There should be no prone restraints. But for the face up restraints, that's a person held in a supine position by at least 2, and it could be up to 7 staff holding the arms and legs. If you need more than that, you need special approval if you need more than 7 people for a restraint like that. And they could be holding the arms, the legs, the head, whatever they need to prevent the person from hurting themselves. Now, lift and carry is when an individual is lifted by 1 or 3 staff, 1, 2, 3, holding their upper arms and wrist and legs if necessary and carried from one place to another. Sitting floor control encompasses quite a few restraints. So that could include, any utilization of an approved physical hold technique with an approved curriculum that requires staff to hold the individual while the individual is sitting. So that could be the basket, the cradle sitting holds, held by arms if they're sitting down. Now, standing restraint holds are similarly the utilization of approved physical hold techniques based on an approved curriculum that require the staff to hold the individual in a standing position. So that could be the lower figure 4, standing holds, security holds, and held by arms if they're standing. All right, so another interesting piece of the 255 is the non-standard restraint. These should occur very rarely because they do not fit within the standard restraint protocols. So keep in mind that Hrc reviews some mechanical restraints like mitts and helmets and specialized clothing and buckle guards, but those are not considered to be in the 255 restraint category and don't require a 255. So that's not one of these 2, just a reminder. The non-standard commissioner approved means that this is a restraint that's not listed on the incident report, and it's been PRC approved though. Commissioner review process is PRC. So you would ensure the details of the restraint are included in the summary comment section of the incident report. And there have been occasions in which a non-standard restraint was approved by PRC. One example is use of a tray on a wheelchair to assist in keeping an individual in their seat. But as with any restraint plan, a FADE plan was developed with proactive teaching strategies to reduce the need for the restraint. There's a plan to ensure the individual gets a 10-minute break every hour, as with any restraint that limits movement for up to an hour. So all that's included in a situation like that. Now, a non-standard, not approved restraint is, again, one that's, not listed on the incident report as a commissioner approved restraint, but it's been submitted for PRC, but not yet been approved. Okay. And again, the commissioner review process is PRC. So you want to, again, ensure the details are included in the summary and comment section. And there have been occasions in which a non-standard restraint was not approved by PRC. And in this case, the team would choose something else to use as an alternative, or, they might par it or go to the commissioner for a review and approval. It's up to, the team and the guardian. Now, there are 4 restraints that are listed on the 255 that are considered excessively restrictive. And these you'd need prior approval before you get the implements to use either of these restraints, any of these restraints. If that approval is not granted, then you'd go to a special review by the regional director or the commissioner. So a body board is used with a body wrap, like the board where they have the body wrap that immobilizes the individual who's aggressive. It has to be in a non-medical situation. It's not when they use a body board for a specific medical purpose, that's not done by a DDS funded provider. So, that would include like body boards, body wraps. 4-point is the 4 safety cuffs, the padded wrist cuffs with the Velcro closures attached, where they restrain both the legs and the arms of the individual. And there's a very specific protocol for how this would be administered. Very, very specific. A B safety belt is that waist belt with the 2 padded cuffs and the Velcro enclosures that's used to help move or transport an individual. So there'd be 2 people on each side, and the belt would be used while the person is walking, with their arms down. Another example is a Bergeron safety belt. And And then lastly, the safety cuffs. That's when less than 4 cuffs are used to restrain an individual to protect, him from hurting himself or others, or herself or others. So again, these need prior approval, but wanted to just quickly tell you what they are. All right, and so now let's talk about physical isolation. That is also listed on the 255. That is an aversive procedure. It is defined as an individual being separated from other individuals served by DDS, usually in a room or a bed by them, or in a room by him herself, with the staff with them, who's physically preventing the individual from exiting the room by physically blocking the door, like maybe standing or sitting in front of it. And the individual is not allowed to leave until defined criteria are met. So staff do not leave an individual alone during physical isolation. The person is isolated from other people served by DDS who live in the home, not isolated from their caretakers. Keep in mind, locking someone in a room and not allowing them to leave is seclusion, and it warrants a report to AID for possible abuse or neglect. Now, I want to just remind you briefly that if an individual is in a wheelchair and they're moved by a caretaker against their will and unable to control the wheelchair, this needs to be properly documented, as physical isolation, that they're being removed from, the situation and circumstances with other individuals. Now, physical isolation is not reported if the individual is asked to go into a room alone and stay there, and nothing, is physically preventing him or her from leaving, even after, a period of time is given, but, they're not being blocked. They're just being verbally asked to take a break. Now, we could spend a lot of time on this discussion, and I'm going to just briefly make a few statements, but to do full justice to this topic, I obviously will not do here in this brief discussion of 255s. But what I do want to say is that, while telling an individual to go in a room and remain there doesn't warrant a 255 for physical isolation, keep in mind the power differential, between staff and the individuals that we serve. So being told to go in a room alone by someone in a position of control or power is definitely not a recommended intervention, for an adult. We serve individuals who self-harm when they're upset, and telling them to go alone without supervision would not be appropriate. They could really hurt themselves if, in a situation like that. And our goal really is to teach skills for self-regulation. Ideally, taking a break is voluntary. It occurs before the individual has lost control by engaging in the disruptive behavior. We want to help, with the precursors. We want to help suggest, would you like to take a break or go for a walk to cool down with me, before it gets escalated to the point when they're, doing some damage. And that's very different, than saying, go away, go in your room, go alone. So, many individuals want to step away when they need a break, and they can be afforded the right to do that and be alone, in that situation. We certainly want to support that. But keep in mind that once the person gets beyond their threshold of tolerance, they do need interventions to reduce risk. So telling them to go be alone can be isolating, and it can intensify, the painfulness of the situation. So PRC, is not going to want to support an intervention that's likely to escalate feelings of isolation and the likelihood of self-harm. So just some caveats around this particular piece. All right, now on to critical incidents. I know there's been some confusion, around what is considered a critical incident or not. So this is just straight from policy, the definitions of a critical incident. And remember too that those require immediate reporting. Not necessarily that the 255 has to come in immediately, because there's some pieces you need, additional documentations to cover, but to call to make the report immediately. As soon as possible, DDS needs to be notified, on-call manager, follow the appropriate reporting protocol. So, you guys can read, you see what's here, but I'm just going to highlight a few things. That natural deaths are not, that are not due to an injury don't warrant a critical incident, okay? A severe injury must also result in a hospital admission. So not just going to the ED for an evaluation, they have to be admitted to be considered a critical incident with a severe injury. A question was asked, you guys did a great job submitting questions. It was asked about whether missing persons also requires the missing persons form to be filled out in addition to the critical incident. And it is our understanding that both the critical incident at 255 and the DDS missing person form is needed once a formal missing person report is filed with law enforcement. So hopefully this will be more clear once policy is updated, because it is a bit confusing, but that is our working understanding. Feel free to follow up with questions directly with case managers and things. So I think the rest are fairly self-explanatory. Feel free to consult, like I said, if you have questions. And per policy, all types of critical incidents except severe injuries will be immediately reported to the appropriate DDS regional on-call manager. And then severe injuries can be reported the next day unless they have a hospital admission. So any critical incident, because if it's a hospital admission for a severe injury, it's a critical incident. So any one of those needs to be reported immediately, using the on-call manager. The policy emphasizes the importance of an accurate report. So if it's not yet determined whether a hospital admission will result, wait for the determination so you can correctly categorize the incident before submitting the 255. But again, still let DDS know immediately. So still follow, the policy. All right, so I'm just going to highlight a few scenarios where a restraint would turn into a critical incident. Okay, so one example is a restraint results in a severe injury. Maybe there was asphyxiation and the person had to be hospitalized and put on oxygen. Okay. Another example might be, a PRN chemical restraint is administered and there's a med error and the person ends up overdosing on Ativan. And so they have to be admitted to the hospital for detox because they also have medical complications and they need monitoring alongside the detox. That's a hypothetical scenario. Obviously, a critical incident would also include if a restraint results in death. This could happen if the individual's airway is blocked, they sustain internal bleeding, they're administered a chemical restraint that results in an overdose fatality, among others. There are many circumstances. So 255s. Events that occur during normal business hours should be documented and submitted by the next business day. The incident report inboxes are included on this slide for each region to submit the 255s electronically. That's the best way to do it if you're able to do that with your agency versus putting them, in the mail and mailing them. We definitely like the non-mail version, the email version. And I mentioned earlier that all of this pertains to individuals who don't live in their own home or their family home. But there is, of course, separate policy for people that live in their own or their family home. So let me just start by saying this 255 OH form is from 2006. It's also in the process of being updated. So just consider this a snapshot of right now. But all the information we've discussed, is pertinent to individuals not in their family home, but this slide is pertinent to individuals in their family home or in their own home. And remember that our goal is to ensure that the family gets proper communication and the case manager gets timely communication to assist and follow up as needed. So this documentation responsibility pertains to paid providers, direct support, day program, to be communicating circumstances and situations. So for people who live in their own or their family home, the reportable incidents include critical incidents, injuries that require treatment by a doctor, non-PRC approved implementation of restraints, and all emergency restraints that are done by DDS paid people. All right, Dr. Duzant.
So we're going to go over data and how that data that you get from a 255, from restraints or otherwise, is very important that it's all inclusive, that you filled out every portion of the form that's possible, okay? Because that will help with your data collection. It will help with you creating data solution-driven interventions, and it will help with your strategies. So we're going to go over and review the Positive Behavior Program policy, which is PR 003. And in it, it talks about data and how data collection should be recorded. So you want to record data on target behaviors that are the problematic behaviors that you are attempting to change in some way, shape, or fashion via the use of medication, aversives, or if you are also in need of using a restraint for a very planned, specific reason. So record the data also that you're trying to replace, okay? So if you have a targeted negative behavior, think about what is the function of that behavior, what purpose does it serve, and can I teach you a new behavior in order to replace that negative behavior? You want to be tracking how that is doing, that teaching process, and how that person's utilizing it. So eventually, the hope is you can shape the behavior to change over to the new positive behavior and more appropriate one. Now, the data should be reviewed periodically. That would include your planned restraint data. You want to know why are people being restrained, even if it's planned. Are there any circumstances that are similar across them? And you also want to be documenting things such as medication changes. Has a dose been changed? Was a 255M actually filed? So was there a medication error that might have contributed to this problem? And when you're collecting all this data, you want to be able to develop a way to show that visually, whether it's tabulated in a table form, whether you put it in a graph, if you put it in a bar chart. Make sure that your graphs are things that make sense, they're readable, and actually shows you dramatically how the behaviors has been changed and what factors contributed to it. Also, on your graphs, try to make annotations in regards to whether things have changed. For example, we've had a pandemic. So were there restrictions in their ability to go to day program, for example? Did they experience a loss in a family member, in a housemate, in a staff? Were there staffing changes because of the pandemic? You have less familiar staff in the house, for example. Those are really important things to put into recognizing your data set so that you can actually attribute that maybe to those environmental changes instead of making maybe some quick rash decision in a medication change. So the next slide talks about your data solutions, particularly using your data to actually drive things. And in using your data to drive things, what you really want to do is think about, particularly for emergency restraints, right? So you had 3 emergency restraints in the past 30 days. You have to be thinking, what is different? What has changed? This is not a person that would typically use restraints on, but for whatever reason, they are requiring it. So be prepared to discuss these variables: who, what, when, and how. Who was there? What was going on in the environment? How did this even start, for example? Also knowing what led up to it, meaning, did something happen in the morning that the person continued to perseverate on throughout the day? Is that a contributing factor to this now emergency restraint? Consider all of those factors when you're thinking about emergency restraints. And also, it's useful to have a phase line data if there's any medical changes, meaning there's a medical status change, or if there's medication changes that may also contribute to it. Pay attention to a lot of variables that we typically don't think about. Sometimes we don't think about sleep, how a person is sleeping, and how it can affect it. So let's think about the types of things we need to consider with restraints. I briefly just mentioned them. Changes in your medical status. So for example, are there blood sugar changes? Are there problems with the person regulating their blood sugars that might make them a little bit more irritable? Is there something we need to follow up on? So for example, if you have someone that's pre-diabetic and they're on metformin, for example, you might be thinking like that and talking with the nurse about those things. Does this person have a thyroid problem? That's what TSH is referencing. And what are, not only is their TSH, but you might be checking for their T4s, for example. And also COVID-19, how has that been affecting the household, the staffing pattern, et cetera? Is the person experiencing a UTI? Some of our individuals who are developing UTI symptoms actually may present very behaviorally challenged. Those are the times that we may be thinking about those issues. Again, staffing changes are very important. You think about this from your standpoint, right? So when you go home to your environment, your family members are the same people every day. Our individuals experience brand new people coming into their home, sometimes on a daily basis. If we're very short staffed and we have to use Delta T or something else. So we want to kind of think about how that's impacting the person. Also, are there staff changes within shifts? So for example, someone who used to work first is now on third, and now you see this behavioral change in a person. Are there seasonal changes or patterns with previous data? You want to look at longitudinal data and how the data is actually affecting people over the course of different seasons. For example, a person might have seasonal allergies and they might be very, very agitated, or they may be hitting their head more because they have so much pressure and congestion. Recent medication changes, that could be medical, that could be psychiatric, that can have an impact. Any losses. Think about losses in terms of staff from death, staff from leaving one program, going to a next. You think about program changes. I used to be in a GSC and now I'm in a DSO. That's different. That's a loss. And I don't think that we think about it that way all the time. The activities that people do right now, that is a loss due to COVID-19 restrictions. In regards to restraints, and particularly on the last day, where we are looking at sexual abuse in terms of just honoring it's not okay. And I hope everyone had a chance to look at our website and some of the movements that we're doing in that regard. Think about a person's trauma history and how restraints can significantly be triggering to them. If you are a victim of someone who has been raped, for example, holding a person down can be very traumatic to them. And some of a person's trauma history actually will be contraindicated. And I want you to think about, even for those people who have problematic behaviors, such as inappropriate sexual comments and inappropriate sexual touching, you want to think about, is that a person that you want to apply restraints to? Because they may be using such opportunities to be opportunistic in nature. So consider those things. Safety concerns. Are there enough staff even present to safely put a restraint in place for that particular person, given their size, given their weight, given the circumstances and the other people in the home, so that you're not breaking protocol in terms of supervision levels? All of this, you want to be thinking about what's in my data sheet and what's important. One of you guys had put in our survey, and this is the next slide, Brooke, by the way, that data sheets are really hard in CCH. Completely understandable, right? Because you want to make it as user-friendly to the person as possible. You may want to only pick a certain amount of behaviors that are really problematic, that really address why the person's on a medication, have that definition right there on the data sheet, and then make it just a yes or no, right? You may just be wanting to find out how often is this even happening in any particular given month. Based on the yes and no's, we can determine whether or not do you need to change the frequency data, if that is even realistic, for example, to change the frequency data, because will you even get the information back? Pretty difficult, depending on if you're in a CCH. So we're going to move along to another subset of data sheets. As I said before, compare the data and your restraints. So for example, I had talked about a sexually inappropriate person, right? Look at their sexual inappropriateness. Look at their talking about the sexual things, and how does that affect then, and how does that correlate maybe with the way or the days that they're being restrained? Pay attention to that kind of data. Also, what other factors are being can influence a person being more agitated or irritable? So look at the sleep data. On the right-hand side, you'll see sleep data. This person did not sleep at all, basically. And now the next day, they happen to get a restraint, because you need to be mindful of how irritable a person might be having experienced a night like that. I think we would all be irritable on some level if we didn't sleep all night, but we're expected to still do everything. So let's talk about graphing and annotations, right? You can use lines to indicate major events in a person's lives, major changes for them, or changes just in their own status, their medical status, etc. So, and you want to be mindful about how you graph things, right? So here's an example of a graph that was submitted to PRC here in the North. And you will see, the agency's tracking a multiple data sets, right? Multiple target behaviors. When you put them all on one graph, it makes it very difficult then to really tease apart what's the worst, what's the best. If this actually came with some numbers in a table form, then you might really see what is the impact happening, and you can put phase line data and what kind of contributes to these spikes in behavior. So let's talk about planned restraints now, right? Where you're thinking about this person, yep, they always require restraint for whatever reason. And in the documentation for that, you know your 255s are going to be filled out, hopefully, in all of its, everything. Time in, time out. You want to know what type of restraints you use, what behavioral events happen that cause you to even restrain the person. And we want you to be thinking in this way about plan restraints. Is just because someone has it planned doesn't necessarily mean that you always want to get there, right? Our pandemic kind of helped us think about these things even more so when you're trying to social distance, etc. So let's go ahead and look at how do you choose to display your data, especially if you're having restraints, right? So I'm going to give you three examples of data specific to restraints. So on the left, you'll see a table where the PMT is being on the right-hand side, and it's telling you how many times this person required PMT. And then there's also behaviors that are coded. So of course, you may not know what the codes are. Aggression to AP is aggression to people, for example. AL is aggression to objects, and there should be a key that goes along with it. And also, would you prefer to put it in this way where you actually see numbers? Or would you then put them in categories so that you can compare it against maybe your two top things that would lead to restraint, for example, and you would then put that information all in at the same time. Now, what I also want you to be looking at when you're looking at your data, this is the last table, Brooke, where you're looking at the frequency and the time of your restraints. So for example, how many restraints have you had to apply to a particular person? And this might be for someone that has planned restraints that happen pretty often. You want to be mindful of that. And then what is your average minutes for that restraint? That is very important because you think about what Dr. Racino's had talked about, right? Dr. Racino's talked about, well, you don't really want to have someone restrained for more than 10 minutes for various reasons, right? It can lead to harm to the individual, it can lead to harm to staff. So you want to look at how long on average per month you're actually holding this person and how many times you're applying these restraints. This would be really good, important information for you to kind of consider and think about as you look at your data. So this next slide talks about, is a planned restraint actually necessary, right? So for example, for the example of, again, something submitted to PRC where you see PMT interventions are at 0. And if this person has a planned restraint, you ask yourself, is this now time to go ahead and discontinue that and really just work on the positive behavioral strategies to maintain that so they don't have to be restrained on a plan basis, but then again, move to more of an emergency restraint. So this is where the status needs to be completed on your 255. So be mindful of, did this person have at one time a PRC approved restraint that now has moved to an emergency restraint? Those are the kind of things that you need to be thinking about. And are you exercising every 10 minutes, every hour to have a person out of the restraint? Now, just briefly going back to the emergency restraints, you should be following up with the team about what led to that restraint. You should be talking about if this behavior, especially if there's a pattern, a time of day, etc., so that whether or not, if this is not in the person's plan, should it be something in the plan, or are there interventions that can be used so that this emergency restraint doesn't have to occur? And sometimes in emergency restraint situations, depending on a person who typically isn't being restrained, as Dr. Racino pointed out, that agitation could just continue and continue, and then unfortunately result to either police being called in an ambulance. So be mindful of those emergency restraints, and are they really, what is really driving them? Because you want to not have them happen so often. So I just want to go back to 255 and some common errors that we're seeing in the region, just to say that we are looking at those, and 255s are coming back, so you guys are very much aware. So for critical incidents that are not defined as critical, we should not be checking that box. I know there was some misinformation about all hospitalizations being critical incidents. We just went over what justifies a critical incident in terms of severe injury that resulted in a hospital admission. So incidents that are critical sometimes are not even marked as critical. So we have a whole slide dedicated to just what the definition is on critical incidents so that we can kind of help, even in our positive behavioral support trainings, those are opportunities to help with these are the things that I'll be looking for when I'm collecting my data, because the 255s will come to you at some point. So if a person went to the hospital, many agencies may check off behavior or other. And may not have a lot of information about whether or not the person was actually admitted. So a person can behaviorally be acting out, of course, and it may not be covered in their behavioral support plan, absolutely, but they may have been admitted to a psychiatric hospital because of that. So those are the kind of things that we're trying to manage a little bit better. And then a large majority of injuries do not have to be, have the severity of injury for whatever reason, that's not being checked off, right? So you have a person who has a behavior support plan that talks about SIB, and you have a level, mild, moderate, etc. You can be using that as a way for staff to help with checking off the severity of the injury if it's related to, say, a SIB that actually was severe in nature. That would line up perfectly with your behavior support plan. So there's fields that are usually missing, unfortunately, and when those fields are missing, then we have to send that back to the agency or to the case manager, and sometimes those summaries don't match with the fields that actually were indicated up top. So we do understand, and we're hoping that everyone remembers that, yes, 255 should be done the same shift, but take some time, because some of the incidents are very emotionally driven and can be provoking just to your sensory system. Take some time to kind of look over, even after you've written it, before the shift ends, to see if you're missing any information. So some statistics from the North Region, for example, for missing information from January until now, we have 104 incomplete ones from private agencies. So you guys are getting them back, unfortunately. And then 66 that are incomplete from our IFS division and 28 from our self-determination. The numbers weren't available for public by the time for this particular presentation. As you see, it's literally real time from yesterday. So just a reminder about critical incidents, and we're just going to leave this slide up so that everyone has this information. And of course, thank you for giving us all your email addresses. That's what's going to help me to go ahead and send you out this PowerPoint. If we had any minor errors in terms of spelling, whatever, we'll correct that before we send it out. But it's really important for you to make sure I have your email address so that you're able to get this PowerPoint. And that way you can be able to utilize it and think about it when you're actually doing your positive behavior support plan training, that you can help highlight the things that will be really important in regards to data. So that's the end of our presentation in terms of content and materials, but I know that you guys did a survey. And Dr. Lloyd, I don't know if you want to briefly go over some of our answers to that survey, or take questions now, Dr. Racinos. Either one of you guys, I'm open to you.
Why don't we do, sorry, hold on. Why don't we do the, well, my suggestion would be, let's do the survey questions, because I know, people had, submitted those. So let's do those first. And then if people do have other questions, if you want to put them in the chat, we can be monitoring that. So once the survey questions are answered, we can then move into other questions that might have come from this presentation, if that works.
All right, so we, as far as the questions, which you all were so helpful in providing for us, we will get started with trying to answer those. And I don't know if we want to just like alternate between us or something like that, or all of us jump in at times. But the first question that was asked was, As far as pre-sedates for medical appointments, are they considered restraints? And Dr. Rosinos did answer that that is not considered a restraint. Pre-sedates are not considered chemical restraints. And she did discuss the procedure for that. So hopefully that question was answered sufficiently. The second question was HRC no longer approves restraints as a restriction. They're referring us to PRC. Is PRC now responsible for approving restraints? So yes, per the policy, PRC is responsible for restraint approvals. HRC approves restrictives and aversives that are not restraints. And, you know, specific items like buckle guards, mitts, helmets, things like that, that are not in the 255. So we did provide a PRC coverage presentation in October 2020 that breaks down what HRC versus PRC covers. So if you'd like a copy of that, feel free to reach out if you don't already have one, because I think it helpfully summarizes the policy around that. I can keep going unless anyone else wants to jump in with question number 3.
I can do it if you want.
Great.
Okay. So the next question was, physical touch can be lacking, or nails on a chalkboard for people. Where do they support, where does support, so hold hugs fit into play? And so the answer that we have is, I think you're referring to people with sensory challenges who can have sensory seeking or easily experience sensory overload when faced with normal demands. There are a number of OT strategies to assist people who need more sensory input to remain regulated, including compression clothing, weighted blankets, brushing, etc. Sometimes OTs will teach ways to apply deep pressure with your hands. These are all voluntary therapeutic interventions that individuals can use. You can request a copy of a PowerPoint previously done by the clinical directors and also DDS OT supervisor that could help with how it is used specifically with people who experience trauma or who have experienced trauma. And then prior to using items, you should absolutely get an OT evaluation, because it helps to know what the person can tolerate, pros and cons of the use with the person, and if the person may in fact be tactile defensive, in which case you probably wouldn't want to use those things. There you go. Hopefully that answered that question.
Mm-hmm. Number 4 is a little bit tricky because all 3 regions do things a little bit differently. So I want to make sure that we acknowledge that. And I definitely know the North region is the one that is most extreme in this one. So, so the question was regarding 3 medications or less review versus a full PRC. Individuals who are prescribed, you know, only 2 behavior modifying medications, but also prescribed melatonin and a seizure medication, would they be required to go to a full PRC, for example? So for that one, of course, melatonin is excluded from being required for a PRC review, but we do see at times melatonin listed, and then we see Ambien, and then we also see maybe trazodone. So one of the questions, and why, at least for the North region, why our psychiatrist is most interested in seeing melatonin is because why is it still there if we're using other medications for sleep, right? So, and also in the North region, we do ask for more than just a medication entry data sheet. So that basically, and if you're ICF, we need a full PRC review period. So just to be clear, you know, we were piloting a separate MIE form, and we were piloting what information would come with it. And so the North region is a little bit different on that. The South region made it very clear they don't count melatonin with the others. Please be mindful, though, if you have 2 behavior modifying medications, but you also have PMT, or you also have you know, other things in place, those count. So that's why you would be coming in. Okay, so sometimes we see 2 medications, you know, being prescribed, but then we have a whole list and host of restrictions also on the bottom. Okay, so we would be looking for you to come in.
I just want to add one thing. As you were saying about ICF, even though I didn't make that part of my answer, that also applies to us as well. If it's an ICF, obviously there are different rules and expectations, and we would be doing the same thing. So I just wanted to clarify that.
Yeah, and thirdly, in the West, that's also the case, obviously, that, you know, it wouldn't fly for ICFs to not do a full review. So as Dr. Duzant was saying, you know, even if you have HRC review of some, you know, restrictives, if you also have medications alongside restrictives, then we are asking in the West for you to do a full review, because we want to look at the big picture, you know, a multidisciplinary team of why these are all, you know, everything's interconnected, and why these are needed. So we would ask that you do a PRC review with the HRC liaison if there are any restrictives. And so we do also ask that that once PRC does the review, PRC would specifically say, this is approved for future MEI pending no changes, and no additions of, you know, restrictive plan, and no medication changes outside the FDA range. We have like a whole spiel of caveats around that. And there is one difference, I think, between the South and the West. With the form, the West uses the MEI that's like the current version, and I think the South uses the previous version of the form. So again, like Dr. Duzant said, just refer to the regions for the nuances between how to submit an MEI between the 3 different regions.
One day we're going to use the same one, I promise. One day.
Yes, yes, we are. That's all under review right now, definitely. Okay, and the other question was about plan protective holds. We basically covered it in the presentation today, so we're going to kind of move over to another question. As people are aging, PT has more involvement, and basically they may be taking over some of the equipment that was previously used, for example, for behavioral reasons. So again, I think, okay, the West and the North, we have 2 different, kind of sort of 2 different responses. But so from the North, what we're saying is if a device was once used behaviorally and is not for a medical purpose, you should change that and just be clear of that in a behavior support plan. A note should indicate fading is not possible if it's considered a medical necessity. And you might say something like, see current medication, medical orders, okay? So that might help you out in that regard. West region has a different.
Yeah, and this, you know, of course, we're leaning on our human rights, you know, groups for guidance around these, and there's some differences between regions. But, you know, in the West region, they do ask for a measurable fade plan, even if you don't think it can be faded. They're asking to define the criteria that you would need to see in order to remove the restrictive. And, you know, of course, you start with proactively trying to intervene. And if the problem continues in spite of adaptive replacements, then you seek approval through HRC. But do identify, you know, a data-driven fade target, even if you don't think it could ever happen, because, you know, that's our kind of responsibility to, you know, make sure we're not restricting human rights. And there are times when we think it couldn't happen, but then, you know, there's a situational change or environmental factor that we didn't anticipate that leads to improvement. And you know, we want to have data that tracks whether there is a shift. But again, it's dependent on the HRC committees between regions, so there's a bit of a difference there.
I just want to add that the South region is not is essentially the same as the North region. What, you know, the explanation that Dr. Duzant just gave. If it was once used behaviorally, but now it's but not for a medical purpose, but now there's a change. We just want to know when that occurred, have a fade plan, and have, you know, say something about the fact that it's a medical necessity, make sure that there's current orders, etc. Do you want me to read the next one?
Yeah.
Okay, I think we're on, let's see. Okay. These were questions for incident, these were incident reporting questions. So reportable to DDS versus critical incident. That was included in Dr. Lloyd's presentation. So there was a question about what's reportable to DDS versus critical incidents. She did address that. The second question was when documenting multiple restraints and occurrences during the same behavioral episode, staff write the time in and time out and also mark the total restraint time and occurrences. When we received our CQIP data, only the time in and time out was reflected. And so the answer is if there's information missing from that CQIP data, feel free to request more detail or more detailed report. It could have been a user error, we're not sure. But DDS reports the information from the 255, so restraints, behavior, time in, time out, occurrences, all the things that Dr. Lloyd talked about that are included into our electronic reporting system, which of course is eCameras. So you may want to talk to someone about that if there's some kind of missing information. The next question, do you want to do the next one? Okay. So the executive briefs summary of changes to incident reporting system that was from July of 2011. Dr. Lloyd did talk about that, mentioned the elimination of a separate missing person form, but in the DDS manual, it still lists that the missing person form should be completed as of 2014. Please clarify the use of that form. So that was included in the presentation as well. The more recently dated 2014 manual should be the guide. The missing person report is still required, as Dr. Lloyd said. The critical incident 255 needs to be completed for a missing person. When the report is filed with the police, then it's considered a critical incident. Hopefully that works. And then the last question for this section, are restraint logs for buckle guards, mitts, etc. still entered into cameras? And the question is, that's a good question. No, they're not. They're submitted as data when renewals are needed, such as part of an HRC packet or PRC with HRC representative, and therefore they're still needed for those approvals, and that was discontinued as of 2011. And then the last section is about questions for data collection.
Yes, for CCH in particular, and the challenges of the CCH section, and so I remembered a bit of it, the question when I was presenting. But some helpful techniques, right? Communicate the relevance of the data to the CCH provider. Try to get a buy-in. How would it benefit them? How would it benefit the individual staying or maintaining a certain behavioral calm within the home? Make sure that the interval sheets are physically in the home, because sometimes some of our CCH providers, as this person had indicated, may be older, and having it be done technology-wise may not be an option. Ask the provider to send a picture of it. So if they're able to take a picture on their cell phone, or have someone like, if the behavioral tech is going out, for example, maybe they can take a picture and send it and forward it to you. Also, call the provider on a routine basis to try to check with data frequency. That might help them also to give you some data where you can be, kind of doing your own data sheet, and when it comes in, check and see if it varies. Also, ask other team members to make copies when they're there for a visit, or maybe they can take a picture on your behalf. Sometimes nursing is there, etc., besides the text. And then also communicate quickly to the provider and the case manager if and when data is missing, to try to make sure you can capture it as soon as possible. Document clearly on the quarterlies the limitations and the efforts in you attempting to create and get that data from individuals. Even if you're indicating that data sheet not being completed or filled out, but from an anecdotal perspective, for example. And simplify your data sheets as best as you can. I try to put a more simplified thing that's just a day, yes or no, so that kind of addresses the question or the problem with CCHs. But we definitely understand the issues.
Yeah, and just to add to that, I know there's a lot of tension, between what the policy says you need for data for people who are on behavior modifying meds, and the challenges, to get the buy-in in CCHs. So, when all else fails, like, go to the policy and just say, look, it's not me, it's not personal. It's just I have to adhere to this, because it's part of how to provide for people's human rights. So, just I have to be able to track data, like Dr. Duzant said in her presentation, that is why we have these behavior modifying medications and the positive behaviors that we're trying to replace, so that the person doesn't need the meds anymore. So a functional behavior assessment, this is the next question, is a physical assessment conducted by usually trained and licensed clinical staff, predominantly social workers or BCBAs. For most agencies, there's not a licensed staff writing the behavior support plans. Would it be more realistic to state that an observational behavioral assessment or residential self-report assessment like motivational scales be used to create outlines for behaviors to decrease and increase? So, a functional behavior assessment certainly is, physical assessment conducted by a trained person. And, we acknowledge that that's the case, but some well-intentioned FBAs do miss, the big picture of the clinical symptomology that may be contributing to the function of the behavior, and that could leave the strategies for addressing the clinical symptoms not addressed by the prescriber or the behavior support plan. So, we do have a qualification process, and there's a, DDS website where the qualified providers are listed, and many of you are familiar and have been qualified. So that's our process for ensuring that people have the skills they need to, write a function-driven behavioral plan. So, agencies are at times deemed the qualified entity, but the supervision with the credentials may be the person that oversees the plans written by those that don't have the credentials but are in the process of getting those credentials. So we do require that qualified providers supervise, any individuals that are writing plans to make sure that they meet necessary requirements for doing an appropriate job. So if your agency is not meeting the requirements, then supervision is required. And so there was a question, I wasn't quite sure what it meant. I'm just going to take a guess. Question regarding receiving PRC qualifications for MEI submissions for items not required to be included. Not quite sure what the question is, but some of the things that are required are, TD screens, consents that are current. And the policy also says that PRC can determine if a full review is needed, at any time. So PRC committee and liaison can say, I actually, in this situation, I feel that it would be more appropriate to do a full review without, it being relevant to something specifically on that form. So I hope that answers that question.
Just quickly, when I first read that, I thought, is the person asking if the MDEI, is that something that we do a qualification for? But generally, we accept it or we don't, right? There's not necessarily a qualification.
Yes.
And MDEI.
Okay, yes. No, that's not true. The North region. Remember, we changed the form and we're piloting a form. And
I forgot. You know what? I'm sorry. That's right. You're piloting the new one. So in the future, we may be doing it.
Could be a specific question to the North, to be perfectly honest with you.
Okay.
So, and that's plausible, that's possible, etc. We recognize that, there were times where, medication data entry forms were being sent in with no other information. So that's problematic, right? Because we don't know what changes you made in your behavior support plan. We don't know, what the data looks like, etc. So the North has been piloting a new form, and it has been asking for things like TV screens, current consents, for example, your behavior support plan, your data. And more times than not, it's just a paper review. So hopefully that answers that question.
I can take the next one if people want. For an initial PRC request, should we wait until there is a BSP in place prior to requesting an initial PRC? At times we may get a date sooner than a BSP is generated. This is for someone who has never had a psych med previously or any sort of BSP. So the answer is no. Please request a PRC date as soon as the person meets criteria for PRC review per policy. This is a placeholder for licensing, QSR, resource management, etc., meaning the PRC date. If you would like PRC to be scheduled after a certain date, please make a note on the request form saying you'd like the date to be scheduled for X many months in advance from today's date, or the date that you're submitting the form, in order to have time to implement the VSP and to collect data for the PRC presentation. The next question was trainings or topics on schizophrenia and schizoaffective disorder and the difference between the two. There seems to be some misconception and confusion on these diagnoses. That's true. So we're going to make that a topic for another quarterly meeting, a future quarterly meeting. So thank you for that suggestion.
The other question was about providers basically refusing to fill out the treatment plan. The treatment plan is, basically, if you look on the front of your PRC face sheet, it talks about it being optional, and providers are required for insurance billing to provide some form of documentation that actually says what diagnostic tools have they used to come to their diagnosis, for example. So I know it was recommended asking for like the intake or the diagnostic assessment that the prescriber did to come to their diagnosis. And then what is their treatment plan? Or there's always a treatment plan. If someone's writing continuing medications and they're on clozaril, well, no, you can't just continue medications on clozaril. You also need lab work that goes with it. So what is your plan? And your plan is to check blood levels for metabolic syndrome, also check clozaril levels, etc. So that should be what we're emphasizing, is the content of what makes you continue these medications and how are you checking them to make sure that the person is medically stable on them. We also got another suggestion about PTSD, trauma-informed care, and positive behavior support plan models. So we'll look to give a topic on that. And there was a question on, does the state encourage parents, medical guardians to attend agencies' PRCs for their loved ones? I will say in the North, we have had parents or medical guardians, if an individual themselves decides to come to PRC, although it's rare, we have had medical guardians or parents come to PRC, and basically we have also, if a parent or guardian has some questions about any of our recommendations, we have set up separately additional time slots within that to actually address those. So you just need to reach out to your PRC liaison if a parent, guardian, or individual wanted to attend their PRC. And then, should lab results be sent in with the packets? We're being asked for them. There are certain psychiatric medications that require the monitoring, as I stated before, like the risk for metabolic syndrome or toxicity, for example, for say a lithium. So as a rule of thumb, you have that information already. Your providers are doing them or should be doing them. And so as a rule of thumb, you can just go ahead and pull out your labs that you've had from a physical and that you got from psychiatry results, etc., and go ahead, scan them in. Better safe than sorry. And some of the prescribers may write what labs they checked, etc., in the notes. So that also is helpful, but not all. While it's most likely not under the influence of this group, it would be helpful if all the most current forms related to PRC and HRC, and along with contact information, be easily accessible on the website. Very true, right? So current forms on the website, if you do a search for the DDS manual under the health and safety section, all of the PRC forms are there, okay? With the exception of anything that's being piloted. So the North Region's medication form basically is not there, and all you have to do is send an email to our PRC email box and we would send you whatever forms that you need. So hopefully that's helpful and you can find it. And any of the forms that begin with PR004, that's related to PRC, and PR006, those are the forms related to any presedates. HRC, definitely, Brooke, I don't know if you asked more questions about HRC and if HRC forms differ across regions. I'm not sure.
Yeah, I didn't look at that.
Okay. So it said for the purpose of choosing the correct PRC face sheet, since all three of us are here at the same time, based on the number of medications, et cetera. So the North region is the only region that's piloting this other face sheet, period. So if you need it, let us know and we'll send it to you. That's never a problem. And, I think there was a question of, do medications prescribed for sleep, seizures, et cetera, need to go on the face sheet? We have some prescribers that, yes, the person is on Depakote or lithium for seizures, but then you notice on the medication orders that now your psychiatrist has made changes to them. So that's now have become a behavior modifying medication because your psychiatry specialty is who made that changes. So I think that's it for our questions on this actual form, but I did see that Chris Parsons asked a question: do responses to PRC requirements and recommendation need to be submitted prior to the next PRC review date? The way that I would answer that is, it is in your best interest for licensing purposes to have that answered, because if licensing comes in and sees that PRC asked all these questions and you didn't address it because your PRC is not coming up as of yet, that can be a problem for you for licensing. I know that a lot of people in the North region, for example, we have some questions. We have some agencies that follow up immediately, send it the same day. They just forgot to include it in the packet or whatever may have you. What we do with that information is we may go ahead, depending on when it's sent to us. If it's not sent the same day, we won't make any modifications on what we write, but we will include it in your file, basically. But this is most important for you for licensing purposes.
From the South region perspective, I would certainly agree with that. If I understood that sometimes things come on that day, we prefer not to have, say, a new behavior program that day because we won't be able to look at it. But if, there was a lab work or something that needed, like a TD screen, something that you just need to include that the doc is willing to look at then and there, that's fine. When I read the question, I was thinking, okay, the PRC review is over with, and the team is thinking, okay, we're gonna send everything in that we asked for, the PRC committee asked for. We don't need that. The next time you come in, we hope that those things will be changed or fixed or addressed in some way. But as Dr. Dujant said, once you have a copy of the feedback, it is absolutely in your best interest to address the feedback and have that updated program or whatever it is you need to update or fix or change in the home for licensing purposes. But other than the day of, we generally don't accept changes or information unless there's some, extreme circumstance. A lot of people are asking about how to get the PowerPoint that we talked about with the clinical directors and OT. And I think Dr. Duzant said if you send you give us your email address, that can be sent out. This presentation, which I hope we can edit.
Yes, we will. We will prior to the video.
We'll make that available to everyone as well, and so that you can share it. And I didn't see any additional. Oh, hold on. Kim said I meant when you received the response page after. Okay, so thank you. I hope I answered your question. Yes, I did. Okay, awesome.
And the response page may be useful and helpful for a couple of different reasons. If that person last PRC was in the South and now they're in the West, or vice versa, whatever, it would be helpful for us to have that the feedback from the other region. More times than not, we're always sending each other emails. Hey, can I get the last PRC? And hey, can you send me that file, etc. One day we'll have it so that we all can potentially see those recommendations, so it makes it a little bit easier for us to navigate moves across region.
We have another question, and thank you for answering that, Dr. Duzant. If plans and meds are approved without qualification, but there are some suggestions or recommendations, why are these referred to as a second request if the team has decided not to follow them? Okay, that's from Mo. That's easy. If you're not going to follow them, maybe let us know that, because if there's no commentary about, if we made a suggestion or a recommendation and you guys are like, yeah, the team talked about it, we're not going to do this. We don't know that. So to us, it is a second request because we haven't seen it addressed. So sometimes people will address that by maybe, writing a short, like I'm talking like several sentence narrative of this was your feedback from last time. This is what the team, or the clinician or whomever has, this is how we've decided to address it. And sometimes it's this, we don't feel that this is necessary, or this particular situation changed, so we don't have to deal with this recommendation or this suggestion, but we don't know that. A lot of times second, let me just speak for the South region. A lot of times second requests really have to do with something that might be part of, say, the prescriber treatment plan. There's something missing in terms of a justification, for a diagnosis. There's not enough information to help the psychiatrist understand what the diagnosis is. Maybe it's a second request for an entire treatment plan, understanding that some providers aren't really dying to relinquish their information or give us their information. So that's where we see a lot of second requests. Another place where can also be repeated requests is with HRC reviews. Our HRC representative, Tanya Pacheco, will very clearly say this needs to come in for a full HRC review, and maybe we'll give that particular team a year or 2 years, whatever, in order to do that. But Tanya will say it needs to come in by this date, and we come to the next review only to find out that's never been submitted to HRC. So then, yes, it will be a second, or sometimes, sadly, even a third request. So I hope that answers the question.
Yes, definitely. And just to add to that, Dr. Racino, just make sure you document that you acknowledge that you read it, and that you made some kind of effort to address it. And if you have chosen that's not the direction you're going to go into, that you understand you're assuming the liability because you actually had some feedback about it. So that's what we should also be kind of thinking and considering. Just document it.
Yep. Thank you.
And sometimes, there'll be a recommendation and the team, doesn't acknowledge it, it doesn't appear like, we said that something was done to address it. And then because it's not been acknowledged, it's concerning, and we turn it into a qualification because we expect, that a recommendation be looked into before the next PRC, even if we don't, have to amplify it to the point of a qualification.
That's a good point. Thank you for saying that. As much as I would like to claim to be a mind reader, pretty bad at it. So any information you can give to us is always useful. Does anybody have any further questions they want to put in the chat, or anything that any information they feel they need clarification on from today?
All the legwork ahead of time with sending in questions, so we could, effectively answer on these topics. We really appreciated, all the input that people gave us ahead of time. And I feel so distant from everybody because we've been talking at you, but not a lot of interplay. So that's a loss we have in all our work ahead of time. So I hope that we're hitting the mark as far as, meeting everyone's needs. The absence of statements suggests as much. And we did, record this so that people who weren't able to make it, or if you want to look back at it later as a reference, we'll be able to send that to you as well.
And we always appreciate any kind of commentary for what you'd like to see in the future, such as, topics you want to see in the future, such as the person who asked about, having the conversation around schizophrenia versus schizoaffective disorder. And I think there was another question about functional assessment, if I'm remembering correctly. We've had conversation about there being a presentation in the future on presenting data and presenting it effectively, because those are places that we sometimes, see a lack of information or maybe too much information. So we'll be doing some kind of presentation around that as well. So I don't know. I'm sorry, I don't want to cut either one of the two doctors off. No. Okay. If that's it, I think that'll conclude our meeting for today. Thank you all so much for being here, for giving us your attention, for sending in your questions ahead of time, for asking